Prof. Kato, the Honorable, the President of ACNN, and Prof. Raja, Simon, Kathy, and all professor and doctor. Good evening, all. Thank you so much for this opportunity. This evening, we will go a webinar about the. I think we go first to Prof. Kato to have a remark. Please, your time, Prof. Kato.
Thank you so much. Unfortunately, Dr. Moji is still, she's not with us now. So, but today's focus on the trigeminal pain, neuralgia, or facial pain. I think it's very, very interesting. It's so frequent. We have so many patients. So I think that maybe from the doctor's aspect and also the nurse aspect, we can listen and study a lot. Thank you very much. So the chair is Dr. Liu.
Maybe Dr. Kathy can introduce our second speaker first. Kathy?
Yes,
Okay.
I'd be happy to do that. Our second speaker today is a nurse, and her name is Anita Sarpong. Anita is a clinical nurse specialist in the outpatient neurosurgery clinic at Toronto Western Hospital University Health Network. She coordinates patient care and she navigates the systems to help the patients get where they're supposed to be and get the care they're supposed to receive. She is an advanced clinical nurse specialist and has expertise in leadership, health education, advocacy, and quality improvement and change management. So I would like to introduce Anita Sarpong.
Hello, everybody. Good evening. My name is Anita Sarpong, and thank you, Kathy, for introducing me. I work closely with Dr. Hodaie, who should be joining us momentarily. So I'm happy to take the first step. I did prepare a presentation, and I did send it in. If that can be pulled up. If not, I can just speak to my role.
Please share your slide.
Do
you have your slide PowerPoint with you?
Yes, I do. I've shared. I can share my screen. Is that what you mean?
Yes, please.
1 second, please.
If you have a problem, we can play it from our side. Is that okay?
Yes. Do you have it?
Yes, someone just sent it to me.
Okay. I'd be grateful for that.
Yes, please. This is the one?
Yes, please. And you can just play the slide. Are you able to play the PowerPoint?
Slideshow, please.
Yes.
Okay. Yeah, good.
Thank you so much. Hello, everyone. My name is Anita Sarpong, and again, thank you for the opportunity to speak today. I am a clinical nurse specialist working with patients with trigeminal neuralgia at Toronto Western's outpatient neurosurgery clinic. I not only focus on trigeminal neuralgia patients, but also facial pain within our clinic. Next slide, please. Trigeminal neuralgia, or TN, we commonly refer to, is a rare condition, but its impact on patients' lives is very profound. As nurses, in my role, it is very vital that we are supporting patients throughout their care journey before, during, and after their treatment. Today, I'll highlight how the nurse specialist role contributes to patient-centered care and improved outcomes. So I anticipate when Dr. Hodaie, next slide, please. Oh, thank you. Well, you're on the right slide. I anticipate when Dr. Hodaie joins us, she will further elaborate on trigeminal neuralgia and the managements that we offer and that she provides for trigeminal neuralgia. But in general, TN is a chronic neuropathic pain disorder of the trigeminal nerve. Patients describe and liken the pain as an electric shock. Some patients have described to me it feels as if screwdrivers being stabbed in their face. So you can only imagine how difficult and how intense the pain is. Also liken it to a burning sensation, and it's usually unilateral on one side of the face. Although I won't go into much depth, I do want to explain that it is really a great opportunity to be a clinical nurse specialist for this patient population. And I want to frame my PowerPoint today, my presentation, on the perspective emphasizing the daily suffering of these patients and why my role is so important to supporting them. Next slide, please. Um, TN is not just physical. It also impacts many aspects of patients' lives. Patients often avoid, because these are common triggers for patients, eating, brushing their teeth, even talking, because these simple actions can trigger their pain. Just to further hit this home, I recall having a patient come into our clinic, young patient. He was about 20 years of age, and he completely had no teeth. Reason being was because of the pain of brushing his teeth was so excruciating. He was not able to perform oral care, and his teeth end up decaying and all falling out. So this is just to give you a picture of the pain, the intense pain that these patients do experience. Many experience anxiety and depression as well, leading to social withdrawal and isolation. And as nurses, we are often the ones who hear these struggles firsthand and have to advocate for our patients to have a holistic view of care. Next slide, please. So the role of a nurse specialist is unique. It bridges the medical treatment with ongoing patient support. I provide triage and assessment for the patients when we first receive their referrals, education, psychosocial support, and I also coordinate care for the patients across the team. Patients often rely on nursing as a consistent point of contact, especially when their symptoms become overwhelming or the patients have a flare up or a recurrent pain that returns. Next slide, please. So before treatment, it's important to educate our patients about their diagnosis, about trigeminal neuralgia, and also reassurance is very key because many have been misdiagnosed or misheard or simply misunderstood. I review medications like carbamazepine and pregabalin, to name a few, helping patients understand the purpose of the medication, the side effects, and how to also titrate off the medication after surgical management is provided, and how to properly wean off. I prepare patients for procedures like gamma knife, and this is one of the surgical procedures Dr. Hodaie offers for TN patients, and explaining to the patients what to expect and outcomes. I also help to reduce anxiety and build a trusting relationship with these patients at this stage because it will set the tone for successful care after and throughout their journey. Next slide, please. Post-operatively, after treatment, I'm a point of contact for these patients, monitoring side effects like numbness, tingling, or CSF leaks. In the odd circumstance, patients need reaffirmment about self-management strategies, keeping pain diaries, recognizing triggers, and also adhering to medications accordingly and knowing when to titrate down. I also ensure follow-up calls and virtual appointments as we see many patients across Canada. And even across country as well, allowing them to catch complications early and provide reassurance throughout their healing journey. Next slide, please. Education is one of my the most powerful tools, I must say. We provide education about the course of TN, what treatments can and cannot do, and set realistic expectations. So onboarding coming into this role, it's a new role that we have introduced at our clinic. And I noticed that there was a gap in patient education. So I created education pamphlets, which explains what TN is, how to journal, what triggers to look out for. And in the interim before surgery, patients can become knowledgeable as to what is going on and how to manage their flare-ups. I also want to mention that this education, and not only education, it's support that I provide to patients and the families, because many of times it is not only the patients that are being affected, it is their families that are also being affected, and supporting these patients through this journey as well, and understanding that their loved ones are a part of understanding and knowing how to support their loved ones do this. I also connect patients with peer or mental health resources to help them manage their pain as well. Next, previous slide, please. Challenges. Thank you. Despite our best efforts, caring for TN patients can be challenging. The complexity of the pain management, side effects from the medication, and the emotional toll on patients all require close attention. Another challenge is that many nurses and many care providers do not know TN and unfamiliar TN. So making the specialist role is very critical in supporting these patients. Next slide, please. There are many opportunities to enhance care. Telehealth has allowed us to maintain strong follow-up and provide support in a timely manner and remotely, and also to collaborate with many different care providers, ensuring patients are supported from all angles. Next slide, please. So trigeminal neuralgia profoundly affects patients' lives. Nurses are very important in supporting and addressing not only their pain, but also providing emotional support, advocating for patients, and also providing education. By collaborating with physicians and the broader team, we help patients achieve the best possible outcomes that they can, and also become aware and advocates for their care. I want to thank everyone, especially the organizers, for having me speak today. Dr. Hodaie also is my mentor and a very, very, very special and dear colleague now of mine that has supported TN patients and neurosurgery in general, and also the neurosurgical team at Toronto Western, and also to my nursing colleagues as well. I would like to give gratitude and acknowledge them as well. Thank you for the opportunity to speak today and to share. Thank you.
Thank you, Anita. That was an excellent presentation. And I think you pointed out the fact that nursing is so important for these patients because of what they go through. I mean, having someone like you to be their point of contact, someone they can call when they have questions, when they don't understand something, is got to be invaluable to them and really helps them on this journey. It also helps their families as well. And I think that coordinating all the different services that they get, as well as the education that you provide, is just it's just got to help these families and patients so much, because I can't imagine the pain that they go through, you know, this unrelenting pain and not being able to find a solution for it. So I know you're very much appreciated, and your role is something that should be looked at maybe in other organizations. So thank you for that presentation today. And I'd like to invite our other commentators, Professor Zhang and Dr. Fong, to comment.
So can I make some comments to
Yes, please.
the presentation? Yeah. So again, it's a really great presentation, and I do appreciate the effort from the nursing support for this patient especially after the operations. So I have some questions to ask about. You mentioned about the pain diary, which I think is very important. So I would like to know, how do you keep your pain diary before and also after the operation? And also, and at the same time, sometimes when the doctors prescribe the medicine, so they prescribe the medication or the painkiller as necessary. So if the patient have pain, so the nurses will deliver the painkiller only if the patient suffer pain. So I think this pain diary, especially early postoperative, is very important to alleviate the patient's pain. So how do you keep the pain diary, and how do you quantify it? And this is my question. Thank you.
No, that's a great question. So I mostly work outpatient. So the pain diary is a part of the education I provide. I really highlight the importance of patients to first describe the pain that they're having, how many attacks or flare-ups they're having, or shock-like sensation they're having. It's very important for them to note how many they're having, because maybe the pain regimen that they're on is not efficient, and that they will need to have a higher dose. So many of the patients, they are able to really explain and have a voice, because when they do come in consultation, sometimes the patients do forget and are not able, or they're overwhelmed with emotion, they're overwhelmed with whatever's going on in their lives. So why I emphasize having a pain diary is because I'm able to objectively see, and also the patients tally how many pain attacks they have a day. So you're able to see, okay, how debilitating it is for this patient. A lot of them state that they're in pain all day, they're bedridden from their pain. So it also helps us to get a good idea, right? And to understand their pain. So after surgery, when they have also pain diary, and they're quantifying maybe how many attacks they have a day, or you're able to see the difference right away. You're able to see even the quality of pain sometimes is different after surgery. So with all this information, it is rich information that we then can bring to the doctors or to Dr. Hodaie during our consultations or our follow-up clinic, for her to also understand and then use this information to then support the patient's pain management and make recommendations as well, or understand maybe what next steps we can offer the patient.
Yes, and I think besides the frequency of attack, the pain score is very important as well.
Absolutely.
Yeah.
Absolutely. This is something that is also asked and reported and recorded, and you can see how the pain either goes up or how they are managing after or before surgery.
So in my practice, so usually after for example, the surgery, for example, the MVD after trigeminal neuralgia, I would try to not to prescribe the initial painkiller for the patient immediately after operation, and to see the effect of of the surgery to the pain. So so in your care, and so what is the threshold that you would ask the doctor to prescribe the painkiller after the operation, or how would you deliver the medication as necessary? So is there a threshold for the pain score that you would deliver?
So sorry, I'm just going to ask a clarifying question here. So are you asking after surgery, are they prescribed all the medication that they were before, or are they not, and then seeing how their pain is managed?
Yeah, just is there a threshold of the pain for the pain score that you deliver the medications? So sometimes because the patient only describe, okay, it's just mild pain, and maybe it's not necessary to prescribe the drug. Maybe you will wait. So is there a threshold for you?
Okay, I understand what you're saying. Thank you. So, because we're outpatient and we don't see the patients enough, we do not manage like the prescription of the pain medication in our clinic. So Dr. Hodaie would usually, if they're at a 4 or 5, we usually try to have them titrate down if they're at a 4 and a 5. So that's the threshold that we would recommend, but we would defer to the family doctor to have close monitoring of their titration. And I provide a titration plan for the patient as well that we send to. We provide education to the patient for them to understand. Because as you know, usually they're not just prescribed one medication. It could be carbamazepine, pregabalin, baclofen, all 3 medications at once, right? So, but depending on that, we do recommend to the doctor, okay, they're at a 4 or 5, maybe they can start titrating down off of one. So we start with one medication first, and then after that, we recommend going one at a time so that it's not just cold cut. It's just slowly after they titrate down. But usually the threshold's about a 4 or 5 is when we recommend to titrate down.
Sure. Thank you very much. Very nice presentation.
Thank you.
Miss Anita, really nice topic.
Thank
Yeah,
you.
well, we all know trigeminal neuralgia has very serious effects people's quality of life, especially patient himself and also his family. I have a little question. Before surgery, if the patient experiences trigeminal neuralgia when eating and its pain is very severe, what kind of work will your nursing progress take to elevate the patient's suffering?
So during that time, if the patient's at a very severe pain level and they're at home, because again, I work in the outpatient, we would recommend that they come inside to the hospital and be admitted via emergency. And then we'll have our APS or acute pain service team assess and also provide a plan to manage their pain if they are going to have surgery. So because you mentioned that's before surgery, correct? So if they're not managing at all with their pain regimen, we consult them in our clinic, and then from there, we would have them admitted via emergency to have the pain service, because our acute pain service team, they're only inpatient. Unfortunately, they're not outpatient service. So if it's really bad that they're not able to eat, they're non-functional, that they need to be admitted, that's what we would recommend.
Okay, thank you. Really nice work.
We can hear you, Kathy.
Click. I would imagine that their mental health is of primary importance to you as you're watching them. I would imagine that maybe some of them, the pain is so great they don't want to live anymore. Do you have to deal with that quite a bit?
Absolutely, to the point that I've started to take metrics about how many patients come in and request MAID or consider MAID. We're taking metrics on that as well, and the number is going up. And a lot of times for beta, patients will say, I can't live like this. I can't do this anymore.
Right.
There's nothing, it's not fair to my family. Their families will sometimes break down during clinic, and you can feel the weight, you can really feel the weight and the heaviness of how it not only affects the patient, but their caregivers, their family around them. So mental health is very, very a big topic we deal with. Yeah, for sure.
Yeah. Thank you so much. You're doing great work.
Thank you. Thank you.
And that concludes our second session.
Thank you. Maybe while waiting for Professor Mojgan Hodaie, we proceed with the third speaker. Giving a great honor to call upon Professor Simon Ilunga, who is an associate professor at the University of Lubumbashi, deputy head nurse at Lubumbashi Surgery and Trauma Center, Life and Health Foundation, Democratic Republic of Congo. Welcome, associate professor. And today he will deliver a topic on neurosurgical nursing in Congo Democratic Republic. Let's welcome him, Professor.
Thank you so much, Professor, for this introducing me. So let me share my slide. Okay. Can you see my slide, please?
Yes, full screen, please.
Okay, thank you so much. It's a great honor for me to talk about neurosurgical nursing in the DRC. May I take this opportunity to pay tribute to one person who is fighting night and day to value neurosurgical nursing throughout the world. And that person deserves honor and respect, Professor Okokato. Thank you, Professor Okokato. And beside Professor Okokato, there is someone, I'm calling her a hero in shadows, Matron Yi, who is doing tremendous job for us. So I usually say that neurosurgery is the brain, and neurosurgical nursing is the heart. The brain can't work without the heart, and vice versa. So in my country, challenges which are faced by neurosurgeons are almost the same we are facing as neurosurgical nursing. So let me introduce you my country, Congo DR. Yes, Congo is located in the Central Africa. It's the second largest country in Africa after Algeria, but it is the fourth in terms of population. We have 45 local languages, and French is the official language. That's why, most of us, we don't speak English. I'm trying to express myself in English. Kinshasa is the capital city, and we have the second greatest forest in the world called equatorial forest. We have two seasons, the dry season and the rain season. My country is among the low and middle income countries. So concerning challenges we are facing as neurosurgical nurses, I may divide them into three challenges. The first one is related to what I can call the training challenge. In my country, we don't have any institution where neurosurgeon can be qualified. Most of them, they study abroad in Zimbabwe, in Morocco, in Europe, but there is no school, no university where neurosurgeon can be trained. And there is no school where neuronurses can be trained. So we do have, for a population of 103 million, we just have 19 neurosurgeons for the entire country, 19. And they are all located in 3 cities. Though we have 26 cities, it's a big challenge. And most of the neurosurgical nurses are trained by neurosurgeons. And they are trained for the sake of the surgery only. And after the surgery, the flag is handed over to the general nurses. That's the big challenge. As I said before, there is no neurosurgical nurses trained properly. And I'm the only one who has been trained, of course. Then we have 19 neurosurgeons, as I said, and they are located in 3 cities only. We have 9 neurosurgeons in Kinshasa, the capital city, for a population of 19 million. And we have only 7 neurosurgeons in Lubumbashi, the city where I'm working, for a population of 6 million. But this province, the Southeast province, with the capital city, which is Lubumbashi, we have so many cities, but patients have to travel even 300 kilometers to reach Lubumbashi. And at the East province, in Goma especially, we do have only 3 neurosurgeons for a population of 1 million. As I said before, we are 3 challenges. We are facing 3 challenges. The first one is related to the training, as I said, but the second one is related to the local health system organization. In my country, there is no, in many hospitals, though we have neurosurgeons, but there is no neurosurgery department as well. Neurosurgery department is a part of what we call the department of surgery. And that is a big challenge in terms of coordination. Most of neurosurgeons, though they work in public clinic, but they also have their private cabinets where they receive patients and they refer them to the big hospital for child surgery, and they bring their neurosurgical nurses. After the surgery, the patient will be led to the general nurses. That is the second challenge. Then the third challenge is in terms of motivation. In my country, let me tell you the truth, nurses who are working in the public hospitals, they are not well paid. They are paid $100 per month. They are not motivated to work correctly. But those who are working in private clinic, they can reach difficultly $300. It is a big challenge, as I said. Then, how can we manage those challenges? First of all, for the first challenge, in terms of training, I think it depends on the policymakers, their goodwill. If there is no goodwill from policymakers, we'll still be facing disasters. They should allocate money for research because nurses have to do research. Also, nurses should educate people, those who have neurosurgical problems, to tell them that neurosurgical problems is not a fatality. Because in my country, when someone has an issue related to the neurosurgery, he thinks that it is a fatality. And they are led to what we call the native doctors. And most of them, when they come to the clinic, it's very late for them. So what we can do also is to encourage nurses to continue education by attending live conference as we are doing now, webinars and symposium. Thank you so much.
Thank you, Prof. Simon. You really have enlightened us with the reality, and I think this maybe is similar to most country in the beginning, even to the developing country before they consider as developed country, and they are the phases that they need to go through, and I think Probably in your country, we hope that the evolution would be faster in view of now people are supporting at least in terms of training. And again, I think you have pointed out correctly. I think localized training is the most important. You need to have your own institution to train. Otherwise, the number will not grow so much, and that is always hindered the reality to improve the care of the patient. And you also pointed rightly that neurosurgery is mostly considered deadly disease. Most of the time, the less emphasis was given, including adjuvant therapy. I think even in some countries, for example, to get adjuvant radiotherapy or chemotherapy, they may be the last candidate in the list. I believe this is the same even in developed country. They consider the
Yes.
least important or least burden disease among radio oncologists, which a big challenge. I think again we can't push the government so much, but I believe that the cooperation among South country will be able to push the agenda so to help each other. I think this is beyond an NGO like us to play the role. And G2G are the most important. We hopefully a nearby country like country in United States, Katie, where Katie is, and also in Canada, our previous Miss Anita, be able to go down nearby, hopefully be able to help out beside the Iron Lady, our Matron E. And thank you for enlightening us. Now I open the session for question. I would like to invite both our commentator. We start with Professor Zhang. Professor Zhang, you have any comment? Professor Zhang not there. Dr. Zhang is there. Any comment from you?
Please unmute your mic, Prof. Prof. Xiaolai Chang, please unmute your mic.
Maybe while waiting, Dr. Ben, any comment from you, Ben?
Yes, and thank you, Daniel, and also thank you, Professor Simon. I'm so interested to know about the condition in Africa because as far as I know, so recently I think more and more association would or NGO are willing to help the neurosurgery of in Africa. So I would like to ask about actually the first of all is of course it's a nursing ACNN webinar. I would like to ask about the nursing care of the neurosurgical patients, especially if they have some neurological deficits, or for example, if they're comatose. How are they cared in your place? And my second question is about usually how the NGO will collaborate or to cooperate together with your initiatives. So usually, how is the relationship established? Thank you so much.
Okay, thank you, Professor, for the question. The first one, when there is a deficit, what we usually do is to refer the patient to the physiotherapist for 1 or 2 weeks. Then it will be discharged from the hospital. Because in my country, there is no assurance. That's a great problem, the great difficulty. Concerning the NGO, I don't know what the question again. The second one?
Yeah, usually I saw that recently there are more and more NGOs willing to help the African countries. So usually what is the condition in Africa? So how do the different, because Africa is very large, and then you have different like provinces or cities like And then different parts may have their own collaboration with different NGOs. So usually how do you connect or collaborate with the different NGOs in Africa?
Yes, they are connected through the Ministry of Health, and most of them, when they come in my country, they are targeting themselves to diseases such as HIV and malaria. And for my country, most of them, they are located at the eastern part of the country because there is war now for 30 years, and they are located at the eastern part of the country. And most of them, they don't come in the city where there is no war. They focus themselves to the eastern part where there is war, but in the cities where there is no war and where we have many neurosurgeons, we don't have any NGOs. Yes, that's a very difficult problem, of course.
Understood. Thank you so much. Any
Okay,
comments
thank
from
you.
Professor Zhang?
Okay.
Please unmute yourself.
I think, Simon, maybe you can send us not only the nurse, but also the radiologist and also the anesthesiologist.
Okay. Thank you,
Simon,
Professor. Thank you,
can you hear?
Professor. Yes, I
Okay,
can
okay.
hear.
Maybe you can have more the leader
Okay.
of the neuronurse or nurses.
Thank you,
Okay.
Professor.
Very nice,
Okay.
very nice
Okay.
presentation. Congratulations.
Okay.
Hi, Hodaie. Hi, Moji.
Hello, everyone. Very good to be here. Very good to see you, Dr. Kato.
Yeah, nice to see you. I remember just we went to the Cuba.
Yes, that's right. That was a few years ago.
Yeah.
Maybe I'll share my screen.
Please.
So thank you so much for asking me to speak and to join this webinar of the Asian Congress for Neurological Nurses. And I'll maybe just start by making a comment about the talk that was just before me about neurosurgery in DRC. I have been to Africa several times, Dr. Kata is aware, and just most recently I have been involved in the care of a patient in DRC who was having an intracranial hemorrhage, and they didn't know where to take the patient. And I have to say that, Dr. Ilunga, everything that you said is absolutely true and very necessary. And importantly, I think at the same time, we have to be aware of sister specialties that we work with very closely, such as neuroradiology and ICU and so on. And obviously, these are things that we assume it and we need to care for our patients, but they're incredibly essential as well for neurosurgical emergencies. So it seems like a huge twist to now all of a sudden talk about trigeminal neuralgia, but I hope that you bear with me because this is an important and in our hands a very common condition, and I don't think that we obviously do not have a particular huge incidence of this condition in our city here in Toronto, Canada, but it does reflect the fact that pain is really a silent condition, and if there is care for it, then these patients will appear and tell you how much distress they're in. I'm very happy that Anita is here and that she spoke with you as well in the first setting. I just, first of all, want to bring you greetings from Toronto, Canada, and welcome all of you here, and also talk to you about some of the details of this condition and how we diagnose it and what are the key methods for treatment. So as you already know, this is a very severe condition affecting the face, resulting in severe neuropathic pain. And generally, patients have a sudden severe jolt of pain that is the result of very mild sensory stimuli, such as touching the face or brushing their teeth. So one of the key aspects of this condition is that it is what we call a stereotypical form of facial neuropathic pain, which means from patient to patient, the expression of pain is fairly similar. And this pain is overwhelmingly on one side of the face, It might affect multiple divisions, such as the forehead, cheek, or jaw, or a combination of these, and typically responds very well to medications such as carbamazepine. And because it is a type of neuropathic pain, then opiate medications is typically not something that works well for this type of pain. It is thought to result from what we call ephaptic signal transmission, which means that effectively the irritation of the nerve fibers of the axons secondary to areas of focal demyelination results in crosstalk and the sending of signals that are expressed as pain. And typically in terms of how we treat these patients, microvascular decompression is the preferred surgical treatment. So this panel describes the arrangement of the nerve and the blood vessels very well. Generally, the nerve right here in yellow has the blood vessel that is in proximity with it. However, in instances, and this is just anatomical variations, there can be contact with the nerve, compression of the nerve, or frank distortion of the nerve. And this is obviously very important because it describes what it is that we do surgically to remove the compression and free the nerve. But there's an important concept that we also need to remember, and that is that the severity of compression, so whether it's just compressing, whether it's distorting, does not correspond with the severity of pain. When these patients have trigeminal neuralgia pain, they have pain regardless, and this pain is extremely severe, and it does not relate to how that nerve is being compressed. There are very few studies that have been done on exactly what happens morphologically at the root of the trigeminal nerve. There's some studies done by Love and Kocham published now well over 20 years ago that show areas of focal demyelination at the root of the nerve. And this is again something that we perceive that it occurs when there's ongoing compression. So there is something very specific about trigeminal neuralgia, and we call this a form of hyperactive cranial nerve disorder. So I want to talk about that and also about some of the pain syndromes associated with the trigeminal nerve, since trigeminal neuralgia is obviously not the only one. So the first thing is the discussion of this concept of hyperactive cranial nerve disorders. It turns out that when a cranial nerve is irritated somehow, either by a blood vessel or a tumor and so on, oftentimes it does not result in a negative symptom, such as when we see when, for instance, areas of the neocortex are irritated. So, for instance, if a patient has a meningioma over the motor strip, then typically they will present with contralateral weakness. So that's a negative symptom. But when a cranial nerve is irritated, oftentimes patients would present with positive symptoms or hyperactive symptoms. So the trigeminal nerve is a sensory nerve. Irritation of the nerve by a blood vessel can result in trigeminal neuralgia, which is a positive expression of pain. Similarly, for the facial nerve, we can have hemifacial spasm. Cochlear nerve can present, and we see that commonly with patients with acoustic neuroma. Patients can present with tinnitus, and so on. And even going lower in the cranial nerves, there are other syndromes described. And for instance, with the vagus nerve, it's quite rare, but patients can even present with hiccups, or they can present with a hemilaryngeal spasm that can present as episodes of cough. So we have treatments for some of these conditions. For trigeminal neuralgia, we actually have multiple treatments. And for some, we actually don't have a treatment, such as tinnitus. If a patient presents with intractable tinnitus, it's a really, really difficult condition to treat. And generally, we may suggest some forms of neuromodulation. The other aspect that's important to discuss is that the trigeminal nerve can be associated with multiple pain syndromes, one of which, and I would say the most common, is trigeminal neuralgia. And these syndromes can be distinguished based on the characteristics of the pain, what the pain feels like, what is the potential etiology for that pain, whether there's associated sensory loss or not, and what the triggers of the pain are. So trigeminal neuralgia, as I said, is the most common one. However, we have other syndromes such as symptomatic trigeminal neuralgia that is associated with patients that have multiple sclerosis, or patients that have trigeminal neuropathic pain, for instance, associated with a tumor in the cerebral pontine angle. These patients often have a pain that is more constant in nature, burning that is associated. So instead of having shocks in the face, they have a constant sense of burning. And they may also have some element of sensory loss, tingling, dysesthesia, and so on. When we look at imaging for these patients, and this is a typical MRI, it's very important to examine the trigeminal nerve. You can see on this side that we see the trigeminal nerve exiting the brainstem fairly unimpeded in its course, definitely in its route. And here it's really rather difficult to in fact see the nerve. We see these two dots, which is the loop of vessel that have actually intersected the fibers of the trigeminal nerve and are clearly compressing it and distorting it. However, I will say that the concept of neurovascular compression is not completely diagnostic of trigeminal neuralgia. This is very, very important to remember. So, in a study done in 2009 by the group of Kim Burchell in Oregon, they took a number of patients that had MRIs and they evaluated these to see what was the correspondence of patients that had neurovascular compression, but they had the MRI for some other reason. Maybe they were dizzy, maybe they had symptoms of TIA, something that was entirely unrelated. And what they discovered is that in people that are asymptomatic, almost 20% of them can exhibit on an MRI evidence of neurovascular compression, but they have no pain. And importantly, in patients that do have trigeminal neuralgia, the incidence of having bilateral neurovascular compression is actually quite a bit higher. It's about almost half of patients have bilateral neurovascular compression. And the nerves that are at the same side of pain exhibit compression in about roughly 60% of cases, leaving almost 40% of cases with essentially no good explanation as to what is irritating that nerve. And this is actually very important, and this has effectively led to many new lines of work, including the work that we do in my lab to identify the microstructural signatures of that nerve, of the nerve that is symptomatic with pain, so that we can understand this concept better and not so much focus on the blood vessel, but focus on understanding the nerve. As I said, trigeminal neuralgia can occur because of other causes as well. You can see here a patient that has a tumor that is pushing right on the cerebral, right into the root of the trigeminal nerve at the cerebral pontine angle. And therefore, I will say that it's incredibly important that every patient with trigeminal neuralgia have imaging, and also imaging that is dedicated to adequate visualization of the trigeminal nerve root. The incidence of multiple sclerosis is different in different parts of the world. It's rather high in Canada and in the Northern Hemispheric countries. These patients have a much higher likelihood of having trigeminal neuralgia if they have MS. And it typically occurs because they have demyelinating plaques in the fibers of the trigeminal nerve within the brainstem. So generally, we do not treat these patients with microvascular decompression, but they can be treated by other surgical means. And of course, patients can have anatomical variations such as the lococtatic loop that is severely compressing the brainstem. Of course, that serves to only stretch and result in additional compression of the root entry zone. So as we discuss these procedures for patients, And as we talk about them, we can divide them into procedures that are more peripheral to those that are more central. And the closer we are to the root of the trigeminal nerve, the more likely it is that the procedure will be effective. Of course, we leave central neuromodulation almost as a separate entity that can allow essentially intervention regardless of prior surgical procedures, and its mode of how it works is entirely different. Outside of that, the surgical treatments that I mentioned include microvascular decompression directed at the root of the nerve, gamma knife radiosurgery that is directed at the cisternal segment of the nerve, and rhizotomy where we approach the Gasserian ganglion through the cheek. And very important to say that gamma knife radiosurgery and rhizotomy are procedures that are done as same-day procedures. The patients have the treatment, go home the same day, and they do not need to stay in a hospital. Just a brief anatomy of the area of the posterior fossa. Again, this is the area of question. This is called the cerebellopontine angle, this angle between the petrous bone and the cerebellum. And through this approach is where we find these cranial nerves. Here's the trigeminal nerve exiting the pons. And this would be our route of approach for microvascular decompression. And after exiting the pons, the nerve heads towards Meckel's cave and go on to exit the skull through their respective foramina. For the purposes of microvascular decompression, we generally perform a small craniotomy at the junction of the transverse and sigmoid sinuses. And this craniotomy is preferred over craniectomy. There's an opening in the dura, so this is the incision that we fashion just behind the ear. It's a small incision. And with the position of the sinuses, we want to make sure that we are just over these this area so that we don't interfere with the position of the sinuses. The burr is fashioned, there's a small craniotomy, and within it we see the trigeminal nerve, and we're able to find a compressing artery, and then we decompress this. This is a small video that's going to show what the procedure looks like under the microscope. Before we start the video, I will let you know that this cotton pledget that we have to retract the cerebellum measures roughly 1 centimeter. And this will tell you the window that we have to work for these cases. So you can see here that there's a trigeminal nerve at the bottom. It looks a bit distorted. Here we have cranial nerve 7 and 8. So we don't have too much room for movement. The substance of the pons is beyond this area, and there's a blood vessel that is putting pressure, and I'm going to pull that out now. And this is called a transposition of the trigeminal nerve. So the nerve is now free, and we're going to put a piece of Teflon that will essentially take away the contact between the blood vessel and the nerve. And effectively, this completes the procedure of microvascular decompression. The rhizotomy, as I mentioned, is a day procedure. It involves some sedation and then a percutaneous approach to the Gasserian ganglion, which is identified using intraoperative fluoroscopy. And we generally use intraoperative neurostimulation to identify the branches. So very helpful, if possible, to have the addition of CT neuronavigation, but it's not mandatory. And one can use a bit of glycerol, so that would perform a chemical rhizotomy, or radiofrequency, which effectively performs a physical or a electrical current to slightly lesion the nerve. And a fluoroscopy is a must. One must always use fluoroscopy to approach these cases. The approach is aiming at mid-pupillary line, and the needle, which enters just at the side of the mouth, about an inch out of the side of the mouth, is aimed towards this junction of the clivus and the petrous bone. So this point is really where we aim. And another thing to keep in mind is that the angle of the jaw is always posterior to where the needle is. The needle needs to travel just anterior to this ramus of the mandible, and this will serve to identify as well the trajectory of interest. So this is our setup. We have fluoroscopy, and the patient is here, and this is our fluoroscopy screen. And in some instances, CT neuronavigation can be added. That is an extra bonus. It minimizes the amount of radiation that is necessary, but it is not mandatory. And the setup using the CT includes frameless neuronavigation. So this is helpful to mapping where foramen ovale is. It's very helpful to do this procedure. It's fast acting, and numbness is obviously the most common effect, and we want that numbness. The numbness tends to be a little bit more gentle with glycerol, but glycerol has become expensive because it has to be a specific grade that allows for injection in the area of the nerve. Radio frequency, there's a charge or an expense for the machine, but after that, it's essentially for free. So it's much, much cheaper that way. One must always check for corneal reflex after the procedure. So loss of corneal reflex is very, very dangerous, and the patient needs to be aware how to care for their eye if their corneal reflex is gone. A third procedure is to perform what is called a microcompressive balloon, which we don't do at our institution. One can also do a branch neurectomy, and sometimes I've used this for patients that are quite a bit older. And in these cases, a specific branch is found, and it can be sectioned. Very important to be sure, because the face will be draped during surgery, that the eye is protected. So you can see here that the eye is draped. You can see the eyelashes here. This is the eyebrow, and we've made a small incision above the eyebrow, and here's the branch of V1 that is coming into this area that we have found, and this can be sectioned. So the peripheral neurectomy can be performed for specific branches. For instance, a V2, one would go just below, a tiny incision just below the eye to find it exiting the infraorbital foramen. And the important one is the third branch, where the inferior alveolar nerve travels through the bone, and therefore one actually needs to drill the bone to find the branch, and that is a little bit more tricky. So what are the advantages of each of these techniques? Macrovascular decompression provides a high upfront rate of long-term benefit, 90% upfront in terms of patients being pain-free, but it's one needs a full setup for this, general anesthesia, and proper care for patients post-operatively. Not ideal if the patient has a lot of medical comorbidities, and there's, of course, risks associated with this procedure. Rhizotomy is very fast and provides quick relief. The goal is to tailor the numbness to the affected division. This is why we have the patient under sedation, so that we can communicate with them. We generally do not perform this procedure if the patient has V1 pain, because that essentially means that they're going to have corneal numbness. Another procedure I want to tell you about for your awareness is gamma knife radiosurgery. Some regions of the world have more of these machines than others, but nonetheless, it's important to know about this procedure and that it exists and what it is that it does. Gamma knife radiosurgery was pioneered in the 1950s, about over 70 years ago, by the neurosurgeon Lars Leksell, a Swedish neurosurgeon, who coined the term radiosurgery about really using radiation in a single fraction and a whole bunch of beams of radiation that meet in one target. So currently the gamma knife machines, and this is why it's called gamma knife, because it uses gamma radiation sort of to simulate the surgical knife. Uses 192 beams, and these are delivered through tiny little beams, and they all meet in one target. So it's a non-invasive procedure. It's a day procedure. If patients come, have the treatment, go home and stay day. It really is ideal when there are significant comorbidities. There's no anesthesia involved, save for some local anesthesia for the frame. And the important thing is that it provides delayed relief and not fast relief. Generally, patients start seeing benefit in about 3 to 4 weeks and up to 8 weeks. And numbness is actually rather uncommon with these patients, and if it occurs, it is delayed. So this simulates how the patients lie in the machine. They have the frame that is applied to their face. They're awake, they lie flat in the machine, the screen is open around them, and they're able to communicate with the nurses if they have, if they're uncomfortable, for instance, or they need to move. The frame is placed, it's a stereotactic frame, so it's placed on their face with some, on their head with some local anesthesia, and they are awake. And what the frame allows us is these dots, these very important dots that they move and allow us to determine where these markers are in a three-dimensional space. And once we have these markers, then we can go on and find whatever structure that we are interested in, import that information into the software, contour the structure, and based on that contour, plan the delivery of radiation. So this is the trigeminal nerve that has been contoured. We also contour the brainstem to make sure the dose of it is kept low. And then we place the target, and the target for the trigeminal nerve is rather straightforward. It's a single target at the smallest collimator chosen, which is 4 millimeters. And then the patient, as I said, lies in the machine and they have the treatment. So we'd use Gamma Knife obviously for a variety of things. This is, for instance, a patient that has a metastatic tumor. Again, we outline that area, we contour it, and we use that to deliver treatment. And we are able to use Gamma Knife as well for patients that have multiple sclerosis, which is obviously very helpful to have another additional tool for their treatment, and even for patients that have dolichostatic structures, as long as we're able to see the nerve. The last bit that I want to talk to you about is just a quick mention on neuromodulation, which can be used for cases that are unresponsive to other forms of treatment. Neuromodulation can take the form of peripheral field stimulation or deep brain stimulation. I have to say deep brain stimulation has now changed quite a bit in terms of how we approach it for patients that have neuropathic pain. And that would be the topic for another maybe full hour of discussion for some other time to make sure that we actually find the correct networks to stimulate. That is the key thing. Peripheral field stimulation is a little bit different. It is much simpler, and we effectively just find the field of pain in the face, and we put these electrodes under the skin to be able to result in afferent neuromodulation and pain relief. So for instance, for a patient that has a pain, let's say in V1 and V2, we would put an electrode above the eye and one below the eye. We would externalize this and monitor the patient for about a week. And if the patient is very satisfied, then we would implant these electrodes permanently. So overall, microvascular decompression is our procedure of choice. It really, in patients that do have clear distortion or compression of the nerve, it addresses the concern for neurovascular compression. So this happens to be the most common reason. But again, there are patients that have pain without having clear evidence of neurovascular compression. So in those patients, we do not have such a strong role for macrovascular decompression, and we might move to other forms. But an MVD really does provide the longest term of pain relief 90% and 75% of patients are still pain-free at 5 years. For gamma knife, it's slightly lower in terms of early pain-free, and then the long-term pain freedom is lower as well, roughly 70% at 2 years, so even less at 5 years. So in my view, one of the key aspects has been how do we study trigeminal neuralgia and what it is that we are able to do for these patients. As I told you before, my focus has been to change the approach to research to studying the nerve rather than the blood vessels. And for this, we have studied both the brain as well as the nerve to understand a little bit what are some of these treatment related changes and whether we are able to predict pain. And this work has led us to do very good imaging of the trigeminal nerve that we're able to do using diffusion tensor imaging, and also studying the brain to understand some of the features that will point someone to be a responder or a non-responder, and whether we are able to use those features beforehand and have a very strong and reasonable conversation with patients to tell them how likely it is that they will be strong surgical candidates. This is something that, of course, every patient wants to know, and it's information that we do not really have to deliver to them. So we're aiming to have precision medicine and individual analysis for these patients. So I talked to you about this concept of the landscape of patients with facial neuropathic pain and the fact that the trigeminal nerve is associated with multiple pain syndromes. What I say, one nerve, many pains. And the key thing is that eventually we want to move beyond just this panel of clinical criteria as the sole identifiers of these syndromes and really have more objective criteria that we can use to help these patients. And on that note, I want to thank you very much for providing us with this opportunity to speak with you. I'm very, very excited that Anita was able to join today. The addition of a clinical nurse specialist has been absolutely instrumental in allowing us to look after our patients. Patients feel that they have someone that they can connect with, that is able to guide them through the many different episodes, such as flare-ups and so on. And this really is something that I would recommend to any institution that has a large number of patients with trigeminal neuralgia, to have a dedicated nurse that is able to help patients navigate through their journey of care and provide them with adequate information, plans of attack, if you want to call it, if they have a flare-up of pain, and really guide them beyond the many, many questions that they have that are just on the verge of surgery, but not directly directly involved in terms of surgical management. And again, on that note, I want to thank you again, and Dr. Kato, it really is a pleasure to see you. I'm happy to answer some questions if there are questions from the audience.
Thank you to Prof. Hodaie for a very excellent, comprehensive lecture. I think this lecture is the best, benefiting all of us, including a young neurosurgeon. And I couldn't ever see so comprehensive lecture before on trigeminal neuralgia. Thank you and congratulations. Maybe I know there's still a lot of issues regarding a non-responder. We're still looking for a reason for whether just neurovascular decompression is sufficient, or there's something else. I just probably one question before I open to our discussion. Do you see, based on your practice, is there any microscopic characteristic of the trigeminal nerve itself, in terms of the bulkiness, volume, colors, especially the difference at the root entry zone, at the compression zone, and probably a more distal location. Whether now, is there anything that based on your working experience, or even those who have been treated before, for example, with percutaneous rhizotomy and fail, where you need to go in surgically, is there any differences that you encounter? Whether the nerve now freely moving or not moving, or very static position, anything that based on your observation may not be evidence-based, but we would like to know about it. Thank you, Professor.
Thank you very much. Very important comment. So yes, oftentimes actually when we perform microvascular decompression, we see actually a lot more than we see on an MRI alone. The arrangement and the level of compression is much more obvious. I mean, it has to be much more obvious once you look at the nerve than when you examine the MRI. And oftentimes, for instance, we see little grooves that have formed from the compression of the nerve by the blood vessel. Oftentimes, patients have sizable petrosal veins that also leads to the formation of a groove, or the nerve is completely sandwiched between an artery on one side and a vein on the other. So this type of arrangement is important to note in every case. The result of this arrangement can also be at times some graying of the nerve that again you can only see under a microscope and not on an MRI, which I think is likely more evidence of areas of focal demyelination and chronic compression of the nerve. One could take this concept further and say, well, we see so much more under the microscope, we should operate on everybody. I suppose we could. But again, the important thing is to study the MRI and to try to fashion the best treatment for each person, because there are times in which one also operates and, you know, it's a little bit surprising that you cannot see so much compression, and therefore it requires a very detailed analysis for every case to make sure that we provide the best care for patients. I also would like to, on this comment, Dr. Liu, add the notion that it's really important to take a very good look, it's almost circumferential look at the area of the nerve. Oftentimes there is the vessel and the nerve, but what is holding them tight together are fibers of arachnoid that are tiny. They're almost, almost invisible until you try to cut them, and then you realize how firm they are. So arachnoid tissue, as much as we think is very lacy, is actually very, very strong. So releasing the arachnoid, I think, is very powerful and very important. And that is one factor that contributes as well to the recurrence of pain after microvascular decompression. The redo cases, generally, there's firm arachnoiditis that's formed around the root of the nerve that needs to be released. So that is something to be noted. I've operated on a good number of patients that have had initially gamma knife radiosurgery, and then they come for microvascular decompression upon recurrence of their pain. Honestly, you cannot tell that they've had anything done. Like, that nerve looks entirely normal. There is nothing to suggest, and if someone did not know that that patient has that gamma knife, you would not really have that, additional technical challenge or anything at all. And I think I probably have one or two cases, very small, of patients that have had rhizotomies and then I've performed microvascular decompression. Generally, I reserve rhizotomies for much older patients, but sometimes, they're just in terrible pain. I subjectively think particularly glycerol rhizotomy eventually can result in increased number of adhesions, arachnoidal adhesions. Obviously, it irritates the nerve and so on. It's nothing that one cannot work around, but it's important to note that obviously if patients have had other forms of treatment, then this may impact their surgical, the technical aspects of their surgical approach.
Maybe one additional question, Professor Hodaie. Nowadays in glioma surgery, we have a so-called invention that to look into cellular in some sort of like electron microscope intraoperatively, where you have probe to detect cancer cell beyond the boundary of a contrast enhancement. So do you think that such a device is applicable in the treatment and also in the study of trigeminal neuralgia. Like you said that you mentioned that MRI, maybe DTI have a lot of limitation. Maybe those devices intraoperatively can give us more valuable structural or cellular level information. What is your comment about this? Thank you.
Interesting. What devices are you considering, Dr. Liu?
No, nowadays I think recently I can't remember the professor name, but they now use a small probe intraoperatively where they can have cellular images, to look for the spread of glioma. I believe you think that whether those cellular imaging intraoperatively will be useful in the further study of this particular issue about trigeminal neuralgia.
I think all of these sort of new approaches are open for consideration. I think they're very important to consider, but we have to be aware that we're dealing with a specific region, in the sense that that region is theoretically, at least, structurally normal, and therefore the abnormalities and what would see with gliomas and so on would not directly apply there. And second is that we are dealing with the interface of the central and peripheral nervous system. We're dealing with the junction, and primarily axonal fibers are the ones that we encounter when we operate. We obviously see the root entry zone, as I showed you also in that brief video. But the primary thing that we see is now the branches of, the trunk of the trigeminal nerve, which is all axons. So we would need something that provides direct information of that area. But I am entirely open to the consideration of new techniques, because this really is really important. It allows us to understand what is happening at the structure of the nerve. And I know Dr. Raja has a question, but I'll just quickly comment that, for instance, when I perform cases of hemifacial spasm, one of and that obviously is a motor problem, not a sensory problem. One of the key aspects that allows us to have high relief of spasm after surgery is the study of lateralized spread reflex for these patients when they're undergoing a microvascular decompression. For a sensory nerve, we don't have such thing. So the addition and the sort of interface of new techniques, I think, is a very important thing, and something that we could easily use during surgery, for instance, to see whether we've adequately decompressed the nerve. But right now we don't have such tools for sensory nerves.
Thank you, Professor. Raja, question from you, Prof.
Yes, first of all, let me thank Prof. Hodaie for this wonderful lecture. It's always a pleasure listening to you. I have a few questions, but I'll start with one. The first thing is regarding the decision to operate. Of course, trigeminal neuralgia is a clinical diagnosis, and several people have always people who have large volumes have always resorted to this philosophy: without a finding, do not go in. So what is your philosophy regarding it? If there is no established conflict, would you go in or opt for a non-surgical alternative?
Very good question. How much time do we have to talk about this, Dr.? Very, very important question. Okay, so yeah, it is an important thing. Without finding neurovascular conflict, don't go in. I understand that. But as I said, that philosophy cannot be cast in stone. There needs to be analysis on a case-by-case basis. There have been instances in which I have not been impressed with the evidence of compression in MR imaging. The clinical diagnosis of trigeminal neuralgia has been made. And in fact, when we operate on the patients, we see very clear evidence of neurovascular compression. And then there are instances in which, one thinks the MR is quite characteristic. It demonstrates compression. But then when you're looking under a microscope, you say, yes, there is compression, but not as much as I expected that there would be. So we don't, and this has to do with the nature of how we acquire MR images, the sequences that are performed, the angle of the gantry, how much of the nerve is visualized in continuity, etc. So that needs to be taken into account. As you said, the diagnosis is a clinical diagnosis, and beyond any diagnosis and surgery, there's a patient. And one needs to understand the patient as well. And if the patient is in desperate shape, then we need to come up with a plan for that patient. I think if there is no evidence of neurovascular compression, I would not have a great interest in performing a microvascular decompression. What am I decompressing if nothing is compressing the nerve? But that patient needs a plan. And as long as we have the appropriate tools to provide that patient with an adequate plan, and I have to say also that plan cannot be only a transaction in time. For instance, if someone comes with classical findings of trigeminal neuralgia and they do not have evidence of neurovascular compression, let's say we recommend a route of treatment such as the ones that I've discussed with you, we are now connected with that patient essentially until the end of their lives, which could be another, 40 years. So how many procedures are we going to do back to back? So we need to take that into account as well, as to, if their pain recurs, what will be the next thing to do? So for instance, on someone that is young, I would never start with a neurectomy. I would essentially limit my options for any type of future interventions. They can then go on to have this aesthetic pain and so on, very, very difficult to manage. Neurectomy is left for patients that are like, plus of 80 and they've already had multiple treatments and now we've reached that endpoint. So all of these need to be taken into account. So the reason I say this is that at times, even if we think that, there's no evidence of, for instance, neurovascular compression, microvascular decompression is not at the top, we end up having that as the best option to offer anyways. And it is worthwhile taking into account. And if there's no significant level of compression, then a neurolysis can be performed, which is essentially just combing the root of the nerve, which is quite successful in settling pain down. So it becomes a rather complex decision tree, but I would just simplify it by saying, take the patient into account, obviously the imaging, and also how long that patient is going to be your patient. Is not just one transaction in time.
Right. Thank you very much. The second question is about in patients with multiple sclerosis. You said you would not go for a surgical decompression, but there are several case series around the world which has published even fairly good results in patients with multiple sclerosis who have undergone MVD. So in presence of a patient established conflict on imaging, would you still treat that patient with a non-surgical alternative?
If the patient truly has MS, then microvascular decompression is likely going to work. But the numbers that I gave you in terms of how long the patient will be pain-free are out the window. So maybe they will be good for 2 months, maybe they'll be good for 2 years. So that level of information that we have for the patients that do not have MS is not available. So this is really important because obviously patients with MS have their disease to deal with and then this pain and all kinds of things. So in having the conversation with the patients, it's important to tell them and sometimes they come asking for microvascular decompression, even if they show evidence of compression at the root entry zone, and even if they have an MVD, we cannot really give them any level of certainty that they're going to be pain-free for a long period of time. So that's worth considering. But patients with MS are a particular group. They need to be studied appropriately. There's now a huge level of investigation of this condition of MS. I obviously, for the sake of time, I did not discuss, but we identified a very specific condition called single pontine lesion multiple trigeminal neuralgia, in which the patients have one lesion only, and it's in the pons in the area of the trigeminal fibers. The rest of the brain does not have any lesions. These patients routinely respond very, very poorly to surgical interventions. And by that, I mean their pain recurs again and again and again. And what happens is a few of these patients were told for years and years that they had multiple sclerosis. And that was their understanding, that they have multiple sclerosis. And then, they were just monitored and monitored. And in fact, what happens is that they have this unusual condition. So these patients should not have microvascular decompression in my view. It is just not going to work for them. Maybe it'll give them 2 months worth of relief. That's not sufficient. So all of these need to be studied, and again, the whole panel or the whole set of tools that we have to help them needs to be analyzed to see what can we provide them that gives them the greatest and longest relief.
Right, thank you very much. Well, I just want to ask one last question. Your choice of procedure between transposition and interposition?
Very individual dependent. If I can do a transposition, I will. Transposition can be challenging. I showed you a transposition on the video. Sometimes as you try to transpose, it's, you're not able to pull the nerve out easily. Please do not pull too hard. The other side of you're not able to pull the vessel easily. Don't pull too hard because the other side of the vessel cannot be seen. And sometimes there are perforators and, other small vessels, and that can cause severe bleeding. So the transposition versus interposition is very individual, and it has to do specifically with the anatomy of the patient. Generally, the vessels that can be transposed easily are bifid. And you saw that in that video as well. There's 2 loops that were attached to the SCA. So that will give you an indication of how likely it is that you'll be able to transpose. But try to release all the arachnoids, because if those are not released, then also it's very difficult to mobilize the vessels.
Thank you. Thank you very much.
I believe there's a question, Dr. Anyaku.
Yes, may I proceed?
Okay, yeah, good evening, Prof. Kato. Good evening, everyone. Thank you so much, Prof, for this presentation. It's a very interesting presentation. My question is, we use Teflon in the decompression. Then, in your experience, over time, does Teflon dislodge, leading to recurrence of this pain? If it does, what precaution do you take intraoperatively to prevent the dislodging of this material? And secondly, still in your practice, what other alternative materials do you use in the decompression? Thank you so much, Prof.
Very good question. Thank you very much for these important questions. Teflon has been reported to become dislodged. I believe the only time that this happens is in instances in which surgeons try to cut a tiny little brick of Teflon and then use that to decompress. I don't use that. I use shredded Teflon. And I've never seen shredded Teflon becoming dislodged. It has this nature to it. It's soft, but at the same time, because of its shreds, it just stays in place. And we have obviously the correspondence between the vessel and the nerve and the arachnoid and so on. And you can tell that Teflon's not going to move. I've not seen that happen, and I've done sufficient number of redo cases to examine that. The only time that I've seen it is when those tiny little bricks are used, and therefore they are not particularly, they have a shape and a character to them that you can see how it could potentially move out of place. Now, the other question that you asked is a very important question. Is Teflon really the only thing to use? So I will point you to an article that was published, I would say maybe 2 or 3 years ago, the Journal of Neurosurgery, by a group in Pakistan, of their report of performing 1,000 microvascular decompression cases using muscle to essentially eliminate neurovascular compression. And I wrote an editorial for that article, which is called A Call for Surgical Equity in the Treatment of patients with trigeminal neuralgia. And I think that article is really worth reading. We sometimes become fixated with the way we do things because that's how we've done them. And, you know, the sheets of Teflon that I have in the OR are 4 by 4 inches, of which I use maybe 1%, and the rest is tossed in the garbage. It's absolute waste. And other groups have been quite successful in using muscle. And muscle obviously is a natural material, and it is able to provide decompression. And importantly, it will not have any associated, unlikely for it to have the formation of a granuloma and so on, which is rare in patients with where we use Teflon, but not impossible at all. I would say maybe 0.1% of patients might go on to develop a granuloma. There is at times in conferences quite a bit of discussion as to whether sealants such as TISEAL and so on should be used, such as when you put in the Teflon, you should seal it. You should put in, for instance, something that pulls the vessel away and tack it to a dura so that there's all these different conversations. Honestly, I don't think the difference is that strong to favor one versus the other. For instance, the people that use a dural bridge technique and pull the vessel away, the people that use Teflon with TISEAL, Teflon without TISEAL, etc. In my perspective, TISEAL is not meant to contact neural tissue. It can lead to thrombosis. That's obviously what it does. And thrombosis of even small vessels can be problematic. So I never use TISEAL. But I think we need to also explore to see what is the best circumstance for our own institution, what is available, what is reasonable to use. And as I said, the key thing is to provide good care to patients, and we can do this in multiple ways. Teflon is not the only way.
Thank you so much, Prof. Sorry, my name is Ike Chuku Aneako. I am a Nigerian, a young neurosurgeon. I so much appreciate it. Thank you, Prof.
Thank you. From our commentator, Professor Zhang.
Professor Mojgan, really very nice talk. You have done a lot of work in trigeminal neuralgia and facial pain, and from the diagnosis to treatment, microvascular decompression, radio frequency, and also the radio and the research. So really impressive. I have a little question for you. Have you ever met the situation where the responsible blood vessel is a vein? Now, how do you treat this situation?
Thank you very much, Dr. Zhang, for this important question. Yes, indeed, I have. And there are instances in which one sees primarily a vein being the vascular structure that is compressing the nerve. So now this brings us to the concept, and I did not go too much into the actual surgical technique, but this brings us to the concept of how to deal with the venous structures when one performs microvascular decompression. As you know, we encounter the petrosal vein when we perform microvascular decompression, and the anatomy of the petrosal vein can have quite a bit of inter-individual variability. Sometimes there is one main trunk, sometimes there's multiple trunks, sometimes there's an early one as you come down, and then you see multiple ones. So I initially, as I learned microvascular decompression, the person that was doing the most, he would always eliminate the petrosal vein and take the vein altogether. But then slowly with time, I moved away from that, and now I do not obliterate veins. I let them be unless they're and I honestly cannot recall when was the last time I had to completely cut down a petrosal vein. So one is able to work around it and leave the petrosal system be. The venous structures that I've seen that have resulted in compression have been sizable. So we're not talking about small veins. They're like big petrosal veins. And then you can see easily how it's really made a big dent in the nerve, and I can clearly see that and identify that as a cause for compression as well. So I decompress it like I do an artery by placing a Teflon and eliminating the contact between the vein and the nerve. One needs to be obviously more careful because veins have a much thinner wall, and it's very easy to just result in a lot of bleeding. And in the same way that arachnoidal fibers can hold down an artery or arterial loop close to the nerve, they can do the same with the vein as well. They can hold down the vein close to the nerve. So that needs to be let down. Now, the other question is, well, if you see that it's a vein, why don't you just eliminate the vein, bipolar, coagulate it, and then your compression will be gone? I would advise that we don't do that. The way the venous system is structured around the anterior aspect of the pons, and Roton has very good articles describing these sort of webs of veins and how these veins support each other, is difficult to study and difficult to directly plan for. Most of the times, these veins are formed such that if you eliminate one, the rest will be able to drain the blood, not a problem. But it's very difficult to tell the situation where that is not the case, and then one could potentially result in injury to the venous system, and particularly veins that appear to come from the brainstem. So as you look down the microscope and you see the nerve is emerging from and then going and draining petrosal system. I would let them be. So I would say that if it surprises you to find that what you have is a vein that is compressing the nerve, decompress it the same way you would do an artery. Make sure that you take, very good meticulous technical care so that the vein is not injured. Release the arachnoid, and again, the benefit of the vein is that because it's a venous system, you can actually push the nerve out much more, and you don't have to compress the nerve as a consequence. And the patients, again, are often very, very happy, and their pain is gone.
Okay, thank you. You have mentioned neuromodulation. How's the pain relief of deep brain stimulation? Pain relief.
Yeah, I did not speak about deep brain stimulation on purpose. There are a number of, now I would say maybe older studies, maybe near about 10 years old and so on, meta-analysis reviewing the role of deep brain stimulation for the management of neuropathic pain, including facial neuropathic pain. It doesn't work that well. It works maybe in about 30% of cases long term. But as I said, as of, I would say, the past 3-4 years, there's been a complete resurgence in terms of how we perform deep brain stimulation for patients that have pain. The standard targets were for us have been the sensory thalamus and periaqueductal gray. But a recent understanding, and this was moved primarily by the group of Eddie Chang at UCSF, has gone beyond using this standard target to understanding the network that is prominent in patients that have chronic pain. And in some patients, that network is primarily, part of the nociceptive network, and therefore sensory thalamus would have a role in that network. And in some other patients, and we've all seen them, pain is there, but what is worse than pain is their suffering, and is the emotive component. And not so much, stimulation of the thalamus is not going to help those patients so much. So there is now a much more involved approach, and we've engaged in that as well. And I've treated one patient with this manner, where we investigate the patient over a significant period of time, by trying to understand the networks that are involved in pain and how these networks contribute to the overall expression of pain. And this is done using essentially stereo EEG electrodes and stimulation and recording over a prolonged period of time of about 7 to 10 days, and then analysis of these networks. And I think this is a much more powerful way of moving not to a single cookie cutter solution for these patients that have neuropathic pain, but one that is individualized, that attempts to understand the key components to the expression and to the sort of consequence of pain for that patient, and addressing those components using a network. And I think using this approach, we are likely to be much more successful than just using exactly the same target for every person. That just unfortunately does not result in long-term pain relief.
Okay. I have last question. Have you ever tried motor cortex stimulation for facial pain syndrome?
Yes, I have. I performed that procedure on a number of patients. And I'm sorry to say that I've really abandoned that procedure, Dr. Zhang. I know Asia favors that procedure, and maybe that's something that you're familiar with. But I have to say, in my hands, I found it to be insufficient to address the pain. And in my opinion, the reason is that we are not using the correct electrodes. We are using essentially spinal cord electrodes that are meant to be over the spinal cord. And putting them on top of neocortex, it's not the right setup for a stimulation. If we had a proper way of stimulating the neocortex with different layout of electrodes, I would be very happy to consider this again. But the way we have it is cumbersome. We either put in like big grids that are used for the subdural stimulation in patients that have seizures and so on, and try to map it that way, or use a strip of electrodes. I just don't think that, using a tool that we have for the spine to now plaster that over the motor cortex is going to give us anything beneficial. And in my hands, we had very sort of limited benefit for those patients.
Okay, thank you. Thank you very much.
Thank you, Professor Zhang. Dr. Ben, are you around?
Yes. So thank you so much, and for this very comprehensive. It's a very comprehensive for different treatment modalities. I do not have a particular questions, but I want to stress that still, from my understanding, I think that the MVD remain the gold standard for the trigeminal neuralgia if the patient failed medical therapy. And I don't think there are so many techniques that I see with like the telephone or the sling using endoscopic, microscopic, or exoscopic. And I think that we still it would depends on the expertise of the surgeons and to decide on which to treat. And thank you so much for your quick lectures.
Thank you very much. I agree with you, Dr. Eng. There's obviously multiple ways, and when we come to conferences, as you know, there's opportunities for multiple opinions and different viewpoints, and I think this is actually very important to explore the different ways, novel ways in which things are done, and that's really how we learn. So I invite all of these opinions, and I also invite you to our in-person conferences where we have longer opportunities to discuss these conditions.
Thank you so much.
Thank you. Anyone else? Any more burning question? If not, then I think and any words from Katie, my co-chair to get Katie, anything from you?
I think this has been a wonderful presentation from everyone, and I learned a lot from listening to everyone. I appreciate everyone coming this morning or at night or whatever it is for wherever you all are at.
Thank you. I think it's time for us to close this wonderful session. We hope to invite all the distinguished speaker again in our future forums. And before we close the session, I would like to call upon Professor Kokato for her closing remark. Professor.
Okay, thank you very much, Hodaie. Long time no see. Maybe we can see each other maybe soon, I think.
I
So
hope
thank
so.
you very much for thank you so much for a nice presentation. And at our institute, we do the microvascular compression more than 200 cases per year. Pure endoscopic, maybe transposition is much better than insertion. Of course, the case by case, some cases cannot transpose because of the perforators and some anatomical difficulties. But I think so far, I think it's very nice result with that. I think. But sometimes the trigeminal neuralgia, there's no conflict. So for those cases, we do the calming. Can you understand calming?
Yes.
I think most of the patients leave the pain. And also another important thing is nurse Anita. Anita, she work with you, I think, at outpatient clinic. I think medication is another very important thing. So even before and after the surgery, the still patient has pain sometimes. So maybe we need such what kind of the painkiller is good for certain symptoms, something like that. So such kind of maybe some rules we need. Then it's we can easy to use. So please let us know in the next lecture, please. Thank you very much for all your efforts to research. Do your best. Thanks so much.
Thank you so much.
Cassie, thank you so much for your nice moderator. Thank you.
Pass back the session to Christine. Christine.
Christine, yes, Christine.
Okay, thank you, Professor. Maybe I would say to thank this is going Professor, Doctor, College, and participant. And this conclude the 19 ACNN webinar on behalf of the organizing committee. Thank you, and thank you for special for Professor Kato, Prof Hodaie, Dr. Eni, Prof Raja, Prof Aniaku, Dr. Katie, Prof Liu, Prof Simon, and Prof Zhang, and Anita Sarpong for speak as a speaker, and Professor Ben, and Mem Yi, and Samu, and Evelyn. And we look forward to see you in next webinar ACNN. Maybe is it a closing from this webinar? Yeah, thank you for all, and see you next webinar. Thank you.
Okay.
Thank you so
you.
much.
Thank you. Bye bye.
Bye bye.